So welcome everyone to the Penn State College of Medicine Understanding Primary Immunodeficiency. It's a Project ECHO Clinician Education Series. We're delighted to have you join us today. My name is Jackie. I'm a member of the ECHO team. My colleague Caitlin is also on from ECHO. So if you have any questions or technical issues throughout, feel free to reach out to either of us. A couple of quick announcements and introductions, and then we'll go ahead and get started. So for those who joined a little bit later, if you're logged in with a name or a number that's not identifiable, please put your name and your email into the chat for our record keeping purposes. And if anyone's joining with you, please include their names as well. We ask that you stay muted unless you're speaking. Feel free at any point, however, to unmute or use the chat. We definitely appreciate cameras and the microphones, but we know that not everybody is able to use them, but feel free at any point to interject if you have questions, responses, and we'll be sure to watch the chat and watch for your raised hands or your unmuted microphones. Please remember that if we're discussing cases, no personally identifiable information is allowed. We are recording these sessions for educational and quality improvement purposes, and we share all materials after the session. In the spirit of Project ECHO's All Teach, All Learn, we're always on a first name basis during our sessions. So today we're going to have a brief talk on steps to diagnosing PI by Kate Sullivan, and that'll be followed by a case discussion. And she has brought a case to share with us. So for those who were at our last session, I want to point out that today's case will look a little bit different from last time. Last time, one of our participants brought a case, and this one is more of a teaching type of a case discussion. So I'm sure you'll find it just as beneficial as the last one. During the presentation and case, feel free to put your questions into the chat. And we have a team of specialists. I'm going to ask them to introduce themselves shortly, and they'll help field questions. But remember, ECHO's All Teach, All Learn, so everyone can share questions and answers. So let me ask our hub specialist team to introduce themselves before I hand things over to Kate. So let's start with Colleen.
Hi, everyone. I'm Colleen Brock. I'm a registered nurse and manager of medical programs at IDF. I also have CVID and have 2 young adult children with CVID.
Thanks, Colleen. How about Paula?
Hi, I'm Paula Now. I'm a physician at Hershey Medical Center, specialize in allergy, asthma, and immunology, including all immunodeficiencies.
Thanks, Paula. Megan.
Hi, everyone. My name is Megan Messick, and I'm the Director of Education at the Immune Deficiency Foundation.
Thank you. Ken.
Hi, my name is Ken Bass. I'm a patient with common variable, and I also am a support group leader through IDF for other patients like me in Texas.
Thanks, Ken. And Diana.
My name is Diana, and I am the mother of a child with PI.
Thanks, Diana. So, Kate, we're delighted that you can join us. If you want to introduce yourself and take over, I'll mute and I'll help watch the chat.
Jackie, thank you so much. My name is Kate Sullivan, and I'm an immunologist at Children's Hospital of Philadelphia, and I work also at the Immune Deficiency Foundation as a volunteer. So I'm going to share my screen. Give me 1 second just to get it set up, and then I'll ask for a thumbs up if it's appearing okay to everyone. Looks good. Thank you so much for the feedback. So I am the 3rd speaker in this really fascinating series on primary immunodeficiency. And as you know, this is part of the Penn State ECHO program. There is some disclosures to be made. I don't have any personal disclosures relevant for this talk, but I'll let you peruse the ECHO disclosures. There are some standards and some references, and I am a consultant for Sullivan and Elsevier, neither of which should be relevant for the talk that I'm going to give today. So you'll be surprised probably to learn that the steps to diagnosing a primary immunodeficiency actually aren't very arduous at all, but we're going to spend a little bit of time because I think the first step is actually the hardest, and the first step is just thinking about it. So I'm going to spend a little bit of time on that, and then some screening labs, and then some more definitive labs. And that's kind of the plan for the day here. For the flash talk portion, then there's a Q&A, and then there'll be a case. So I'm going to take a tiny detour at the beginning because I personally think the nomenclature is a little confusing. So I'm going to try and use the term primary immunodeficiency, PI, It's a commonly used acronym. An alternative that is equally in use, but perhaps slightly problematic because it shares the acronym with another disease that's unrelated, is PID, for primary immunodeficiency disorder. And then among immunologists, there's increasing use of the term inborn error of immunity, which I'll be honest with you, it's not perfect. So the inborn error of immunity was fostered because of this idea that when people think immune deficiency, they think infection. And so the concept of inborn error of immunity was to try and get people to think somewhat more broadly about conditions affecting the immune system. So all three of these are in fairly wide use. They all reference the same thing. Boy, do I wish it was simpler, but it's not. So I'm just going to confess this up front and move on and try and restrict myself to using the term PI. So here are the steps to diagnosing a PI. First of all, you have to think about it. I will go over the screening test, but I'm actually going to spend most of my time on thinking about it. And then I'll talk a little bit about definitive tests, which increasingly, but certainly not exclusively, are genetic in nature. So that's the plan for the day here. So when should I think of PI? Well, I think the easy one to latch onto, but sometimes the hardest to execute, is recurrent infections. And it's hard because there's not a recipe. It's not like 4 sinus infections, you get an immune workup, 3 sinus infections, you don't. It's not really quite that easy. But the physician or the caregiver should have a sense that the infections are excessive. Now, this in some ways is the easiest one because it's a relatively small set, at least among adults, it's a small set of tests that are appropriate to order. So recurrent infections, I think, is the easiest, but it does require us all to step back and say, oh my goodness, that was the 10th course of antibiotics this year. So it does require a perspective that's outside the here and now, which in American healthcare systems today, healthcare delivery is very much about the here and now. Second bullet is peculiar or opportunistic infections. And I use the word peculiar to kind of encompass a number of different things, including severity. So as a physician, I've seen many cases of pneumococcal pneumonia, but there are some cases where it's just terrible. It's hard, the course of antibiotics is very prolonged. Maybe there's a big empyema that needs to be drained. So there's something about that one pneumococcal pneumonia that just looks out there. It's not on the same scale as the other patients. I think a little easier for all of us to sort of conceptualize are opportunistic infections. So someone who's got a normal immune system should not be getting pneumocystis jirovecii, should not be getting aspergillus, right? When we see those things, we know something is amiss. And so I think in some ways, the opportunistic infections are actually a little easier for us to think about. I think we're very well trained in thinking about HIV and recognizing opportunistic infections when we see them. And then the last bullet is another tricky one. So pleomorphic or unusual autoimmunity or inflammation. What do I mean by unusual? That's not a very easy concept, but the wrong age is probably the easiest way to think about unusual. So people get lupus, people get inflammatory bowel disease, but generally teenagers and adults. If you see an infant with IBD, if you see an infant with lupus, that's just, again, it's too out there. It's not on the normal spectrum of the disease as we understand it. And then the last sub-bullet is if it's just autoimmunity that is so bizarre, you can't even put a name to it. It's multiple organs, there's no characteristic autoantibodies. If you've got someone like that, it's often a sign of an inborn error of immunity or immune deficiency. So let me just give you a little bit of data just to sort of round this out. I'm not saying work up every person who's got lupus at age 10. That's not what I'm saying at all. So let's start with recurrent infections, which, as I said, I think it's the easiest because it's already in our heads when we think about immune deficiency, but I think it's the hardest in some ways to operationalize. So let me just give you a little bit of data here just to give you perspective on this. So chronic rhinosinusitis. Now, these numbers are taken from about 4 papers. All of them are tertiary care referral centers. So it's going to be a little different in the community, but it's the data that we have. So among tertiary care referral centers for chronic rhinosinusitis, 10 to 20% of those folks have an antibody disorder. That's high enough to step back and think about testing. What about COPD with frequent exacerbations? Among those populations, 20% have an antibody disorder. In children, I think it's trickier because there's a broader kind of spectrum of numbers of infections at different ages. But I would say a child who's having more than 6 courses of antibiotics in a year, it's worth at least stopping to ask, is there something I'm missing here? Should I at least think about an immune deficiency? So that's the recurrent infection. So you can see it's not an expectation that in these settings, every time you send testing, you're going to find somebody. But I would suggest that these are reasonable landscapes to consider doing testing, particularly on the adult side. What about peculiar infections? Well, we've talked about the opportunistic infections. It's certainly not limited to pneumocystis and aspergillus. You could add bad CMV. You could add warts that take over a whole hand or a whole foot. But the one I'm going to highlight for you is actually Streptococcus pneumoniae sepsis. Now, when I think about sepsis, to be honest, I don't always get an immune workup. I tend to think of it as bad luck. But in fact, study after study has shown that pneumococcal sepsis has a significant signal of immune deficiency. And so we should be thinking of some of these single episodes of serious infection as an anchor for working at primary immune deficiencies. Just to give you a sense of that, I want to show this flow diagram. There are actually multiple studies published that are similar to this, but let me just give you a sense to explain why it's hard to just have a checklist. 6 ear infections, 2 pneumonias, 3 eczema. You really have to think pretty broadly when you're thinking about infectious susceptibility. So in this study, they looked at over 3,000 adults in a medical intensive care unit. They actually took out a bunch because they already knew why the people were there. They had a malignancy, they had end-stage renal disease, they had HIV. There was some known reason that they had gotten so sick that they ended up in the medical intensive care unit. When they took out all of those cases, they were left with 34 folks where they sort of looked at the records and said, shrug, I can't figure out. They were young, they were healthy. I can't figure out why they landed in my intensive care unit. Among those 34, 6 ultimately had an immune deficiency. That's 18%. So again, just another way of framing out this idea that it can be one really bad infection. It doesn't have to be recurrent infections. So why do I need to worry about autoimmunity? So you may remember that back at the beginning, I said we should also be thinking about peculiar autoimmunity. And then I didn't define peculiar. So let me just tackle that now. So most adult onset classic autoimmunity like rheumatoid arthritis, lupus, Sjogren's, inflammatory bowel disease, you don't have to worry about it. Most of those folks are just fine in terms of the structure of their immune system. They're not fine, they've got a bad disease, but the structure of their immune system isn't how they got there. When you see onset less than 5 years of age, you do want to start thinking, maybe this is the unusual autoimmunity she was talking about. So onset less than 5 for lupus, for inflammatory bowel disease, we actually know what the rates are. So for inflammatory bowel disease, 10% of kids with IBD at onset less than 5 years of age actually were born with a flawed immune system. They were born with a primary immune deficiency, and it's manifesting as inflammatory bowel disease. Similarly, for lupus, it's about 20% for onset less than 5 years of age. So again, just to frame out the perspective that in these early onset cases, you are going to find a signal of primary immune deficiency. Is it important? It is, because if you find the genetic etiology, it tells you the best treatment for those kids. So it's well worth the effort. Now, I picked early onset, I'm a pediatrician, but there's other ways to conceptualize peculiar. And what I would say is autoimmunity that doesn't have a name. So as an example, I picked autoimmune hepatitis plus arthritis plus interstitial lung disease. That's not a common constellation. If there is a very strong family history of autoimmune disease, and then my last sub bullet is, if you have a patient that looks for all the world like they have celiac disease, but they're just not getting better on a gluten-free diet. And they swear up and down that they are sticking to that gluten-free diet. Small bowel enteropathy actually has a very strong predictive value all on its own with no other autoimmunity for a primary immune deficiency. So this is a little bit of a mixed bag. I get it. It's a little harder to assemble into a concept, but it is all peculiar autoimmunity, either by virtue of age or organ system involvement or failure to respond to a typical therapy. Now, this category is sometimes referred to by immunologists as immune dysregulation. It's meant to be the counterpoint to immune deficiency, because people tend to think of autoimmunity as too much of the immune system and immune deficiency is not enough. So it's meant to be kind of the yin to the yang. I think this is a tricky group. It's hard for us as physicians as well. There's not a great definition. You can see how much I struggled on the previous slide to try and build a concept for you. And in the end, I was left with peculiar autoimmunity. That's not the greatest definition. It's kind of where we are, though. It's also a tricky group because the screening labs that I'm going to share with you in a minute are usually normal. So they're not very helpful in this particular group. Also, this is a group that is really important to pay attention to for family planning purposes. Many of these are autosomal dominant, and the likelihood of passing it on to a child is quite high. And the people in the same family with this genetic condition can actually look pretty different. Some can have thyroid disease, some can have enteropathy, some can have lung disease. So this is a tough group. I don't want to whitewash it for you. This is a tough one for all of us to grapple with. So I'll come back to this in a sec. You might wonder why I'm spending so much time on the tricky group, and it's because it's not an insignificant sector of the folks with primary immune deficiency. So this is a beautiful paper that came out at the end of 2021. They looked at 16,000 people in Europe diagnosed with a primary immune deficiency. And let me just show you this one graph from the paper just to drive home my point. So across the x-axis at the bottom are different age bins, ranging from infancy to older adults. On the y-axis is the percentage of the whole population of people with primary immune deficiency. Now, this top line that's in black is infection. It's what we've been talking about today. Infection is a strong presenting manifestation of primary immune deficiency. This purple line at the bottom is kind of a funny group that they sort of smush together. It's malignancy, it's syndromes, it's family history. So I'm going to ignore that for the moment. And I want you to pay attention to the green line and the tan line. This is immune dysregulation either with or without infection. Notice that it's not as many people as infection only, but it's a significant sector of the pie. And across all ages, it's about 20%. So while it's a smaller group than infection, we can't ignore them. All right, well, maybe I've sold you. I hope I've convinced you that it's important to think about primary immune deficiency. And why should I bother? Can't I just keep treating them with antibiotics? Well, you can really improve their infection pattern by recognizing the immune deficiency and getting them the appropriate treatment. Even more important, believe it or not, is for those folks with autoimmunity, knowing their genetic driver will actually tell you the right medicine to use. It's really quite powerful. And then I've only talked about it once, but the importance of family planning should not be overstated. Many people are diagnosed as young adults, and so they're in the midst of trying to plan a family. And so this can really be very important at a personal level for them. So you worried about immune deficiency. We've gone through the think of it part. Now, what do I order? So adults with recurrent infections, you want to get immunoglobulins and IgG, IgA, IgM, and IgE. This is about $300 at commercial labs. It's not hugely expensive. I also always partner it with titers. These are the antibodies that people make after vaccination. I use these three because it's a yardstick. Tetanus titers are always the strongest, diphtheria is in the middle, and pneumococcal is the weakest. So depending on how well people have responded to those vaccines, it gives me a sense of how dense their immune deficiency is. always think about HIV, always think about allergies. Allergies are a very powerful driving force for recurrent infections. And then for an older adult, you want to think about malignancy. So CLL would be the most common, but thymoma and lymphoma also lead to recurrent infections or peculiar infections. What about opportunistic infections in kids? Well, this is either going to be a myeloid cell problem, usually a neutrophil problem, or a T cell problem. And so you want to measure the T cell numbers. That's a reflection of how adequate the production is. And then for fungal and mycobacterial infections, the most common specific primary immune deficiency is chronic granulomatous disease. And there's one test for that called the dihydrorhodamine or DHR. Also want to think about HIV. Vertically transmitted HIV, fortunately, is much less common than it used to be. The number of babies born with severe combined immune deficiency is about 50 per year in the US. It's about 50 per year get vertically transmitted HIV. And so just to give you a sense of the likelihood. If your screening tests are normal, remember in that immune dysregulation group, there are folks who have normal screening labs, and then you have to go to genetics. So if your suspicion is high and your screening labs are normal, don't be afraid to go to genetics. For adults, it's the same labs, but I've ordered them a little bit differently. In adults, you're much more likely to encounter HIV or malignancy. You would still want to think about the T cell numbers and the dihydrorhodamine. And again, I think people neglect genetics a little bit in adults. We tend to think of genetic conditions as affecting kids and not adults, but that's actually not true at all. So for immune deficiencies, people can present as adults, even though they have something they were born with. Well, just to say one more time, for the immune dysregulation conditions, when you see those folks with funny, peculiar autoimmunity, in those circumstances, I put genetics very high on my list because I know the likelihood of the screening labs being positive is fairly low. Okay, I hear you. The tests make me crazy. I get it. Boy, the nomenclature is terrible in immunology. I get it. So don't worry, the Immune Deficiency Foundation has a consulting immunologist program where you just go online and type in a question and say, help, I don't understand this, and they'll help you out. You'll get a consultant who can answer your question specifically. And I'll just come back to the beginning. The most important thing is your clinical judgment more than any testing. If you feel that your patient has an immune deficiency and you've struck out, it's time to bring in an immunologist. It's time to pursue genetics. It's time to take a turn and try something different. Clinical judgment always trumps testing, although I think we are all very informed by our testing. And so I'm going to end there and open it for questions. Hopefully this has sparked your enthusiasm. There we go. Yes, I think we're all back now, right? Let's see, I do see a couple questions in the chat. So let me just read the first one from Tracy. For patients with chronic sinusitis and elevated IgG, I don't think there's a history of autoimmunity. Any suggestions? So it depends on the age of the patient. When I see a really, really high IgG, I worry about multiple myeloma. I'm sure it crossed your mind as well. If it's just a smidge high, it's probably a reaction to the recurrent infections. I do always check titers, even if the IgG is high. There is an entity which you might have heard of called specific antibody deficiency. The definition is a little problematic, but it's a normal IgG with poor vaccine responses. And there's a fairly specific definition for it, but that's the concept of it. And so if I see someone that has had a lot of infections, I don't just stop at an IgG level. I do check titers. I hope I'm pronouncing your name correctly. From Dosange. If I pronounced it correctly, may I have the citation list? Yes, I can send that back to the ECHO organizers. From Robin. Robin made an excellent point. We also add a hip titer to our labs. Is this adding extra benefit or just more cost? You know, I work with a lot of immunologists and there's not really great consensus. There's a woman who you might know who's very famous who says, get every titer you can at the time of the workup, because if you start immunoglobulin, you'll never be able to get them again. So I think there is, I don't personally do it, but I think there is sense to that. So I would never say no to a hip titer. And then Karen says, when you say aspergillus, are you getting IgG and IgM to rule out ABPA? No, I was using aspergillus as an example of an infection that's opportunistic, such as you would see in chronic granulomatous disease. But Karen, you make a good point. I listed allergies as a cofactor for recurrent pulmonary infections, but ABPA is also a risk for recurrent pulmonary infections. So you make a good point. So thank you for that. And Judith, oh, Judith, you brought up a very thorny question. So I'm just going to read it out. Do you check IgG subclasses? So I seldom do, not never. It's because I'm a pediatrician. So in pediatrics, the evolution of the IgG subclasses is very age dependent. So I won't check it at all for kids under 4 or 5. If I have a teenager that I think is maybe drifting into common variable, I'll get subclasses then, looking for asymmetric dropout of the subclasses. So I'm glad you brought it up. It is more of an adult practice than a pediatric practice. So thank you for bringing that up. Sahar, sorry, this is a longer one, so I'm just going to pre-read it a little bit. Oh, Sahar, excellent point. So I'll just read this one out because it makes a lovely point. For patients about to receive Rituxan, I now check an IgG A and M and IgG subclasses, as there's some data indicating that those with a low IgG are more likely to get infections in the course of their treatment. Can we discuss risk and cost analysis of whether I should add vaccine titers to that? So Sahar, you are 100% correct. I believe that's Sarah Barmettler's work, and she did show that the lower the IgG at the time of receiving the first course of rituximab was a significant predictor for infections. And you will recall in that paper that a significant number of those infections led to hospitalization, and there were even deaths. So I would say really hard to argue against getting a baseline IgG A and M. Remember, it's about $300, so you'd probably have to overdo it by several hundred patients to equal out on a purely financial basis one admission. So I would say you're on firm footing doing that. And then should I add vaccine titers? I'm not sure that's obligatory. We do not do that at my institution because people have waning immunity to vaccinations, right? We're supposed to get our tetanus boosters every 10 years. So if someone's at the far end of that 10-year cycle, their titers may be low. Not very many people get their pneumococcal boosters until they turn 65 again. And so it's not that unusual for the titers to be low. So it would delay giving the rituximab if you went to the effort of giving them a booster shot and then asking if they would respond. So I don't think that part is necessary. Sorry, that was a rather long answer. Apologies for that. Gonzalo has said, do you measure serotype titers or a global response to the 23-valent vaccine? It depends on the lab that you send it to, but I don't know any that do a global response, although you can get a strep pneumo titer. Usually it's broken into serotypes, and each lab has a different panel. Some will offer the full 23, some only offer 7 or 12. So get the one that you can get. And then Paula is saying, back to Judith, that she does not get IgG subclasses. She gets total immunoglobulins and vaccine titers only. And Paula, I'm guessing that your reservations about the subclasses are slightly different than mine, but you don't find them to be.
Yeah, so in general, my understanding from the literature is they really don't add too much benefit. And in fact, the concern is a lot of false information, getting a low IgG1, and then what do you do with that information without really adding to the overall picture. So the general recommendations from is to get the and that's how I practice. I just get the global immunoglobulins, IgG, IgM, IgA, and the vaccine titers. I actually just do the tetanus for the strong vaccine response and the pneumococcal for the weak vaccine response, and leave the diphtheria out, but you can include the diphtheria. So each person does things very differently, but as long as we're doing something relatively similarly, and I mean, I actually wanted to thank you, Kate. I trained under you at some point so thank you for all that, and thank you for your wonderful talk.
Thanks. Do you want to tackle Karen's question as well? She's having trouble getting approval for Pneumovax.
Yes, so I've never had that. I'm in adults only practice. Karen, I assume that you're in pediatrics. Is that what I'm understanding? That because it's a peds pulmonology. So I've never heard of that being an issue. Kate, have you had that issue as a pediatrician?
It's approved for those over 2 years of age. So I'm surprised that you're getting pushback.
I can add that my son had the Pneumovax as part of his workup early on, I believe at the age of 4. And it was terrible response at that age. And then he had the vaccine again, and then it was tested on a 3-month basis after that to see when he dropped off.
Yes, thank you for adding that little piece, because I had mentioned that there's a very formal definition for specific antibody deficiency, which is a smidge controversial, but it does involve, I'll just say, there's, it can be defined by failure to respond to the vaccine at all. You give the booster shot, you don't see a rise in titers, but there's also a group where they make an initial response to the Pneumovax booster, but they lose it very quickly, and that's called type 3 specific antibody deficiency. So I just want to call out your description of the schedule of repeating it.
For Judith's comment, so you mentioned, what if your IgG number is okay, the total IgG, but you have a poor vaccine or an okay vaccine response, but the subclass 1 and 3 are low, and you already started the patient on Hizentra. And this is the exact reason why I don't check IgG subclasses. So technically, this patient would not, based on what you're giving, the information that you're giving me, and not knowing the other parts of the immune system, but just based on the information, wouldn't fit the diagnosis of CVID, and really wouldn't fit the diagnosis of specific antibody deficiency, because they have an adequate vaccine response. And so that would be a patient that I probably, depending on the scenario, but probably wouldn't have started on Hizentra in the first place. And so that is a tough one. That is a very tough one. So this is that's the main reason why we try to avoid checking for subclasses, because in general, I don't think that they're very helpful. I'm speaking the adult population.
And then Gonzalo had asked, what's a good response and protective value against pneumococcal for you? So there actually is a definition, although it's being revised. So, the normal is what's defined. Normal is at least half of the serotypes either double from their pre-vaccine state, or at least half enter into the protective range, because there is a ceiling effect. You can't always double if your titer starts off really high. So that's the formal definition of a normal response. As I said, it's a smidge controversial, and it's being rewritten right now. Other questions? Do the patient representatives want to comment on some of this excellent dialogue?
When you were commenting on noticing how many infections, one of the things we mentioned last time was that For myself, I was challenged by my doctor to record all the different infections I'd had, because I was going to different doctors, different, places to get the diagnosis. And so they weren't able to see it all stacking up. And so sometimes you have to ask the patient to start recording that so that you have that accurate picture of infections.
I'm going to add a trick that a patient taught me, and that was she came in having downloaded her CVS prescription list, which was actually really valuable. So
That's good.
thank you to that patient.
That's a good idea.
Just going to circle back for a second with something that we did discuss last week and that you brought back today, Kate, which was when to screen patients that have autoimmune disease. And I think this one's really important. I think it is a little bit controversial in our field right now. Some immunologists are saying, more screening for those with a wider range of autoimmune disease. Certainly, I think the autoimmune cytopenias, where those have somewhere between 10 and to 20% have a risk of primary immunodeficiency. There's a recommendation of screening for immunodeficiency. But I did want to impart in the group just that not everybody that has, as Kate was saying, not everybody that has lupus, or not everybody that has, in my viewpoint, and again, there's arguments on both sides, but not everybody that has rheumatoid arthritis, not everybody that has Hashimoto's thyroiditis should not be screened for primary immunodeficiency in the absence of recurrent infections.
Yes. Well, that was a lovely discussion. I'm just going to transition to a case, but I've actually built in some conversation points. So I hope the vibe of engagement will keep going. So give me 1 second here. All right, so I just brought a case of my own. There's nothing very radical about it, but I think it's sort of a practical exercise for us to put into place some of what we've been talking about. So this is a young man who was in good health generally. He thought of himself as a healthy person, but when he was 18, something happened. So he was in college, he was in the dorms, and he got sick a lot. Now, probably many of us identify with this exact phenomenon. It happens. But at 20 years, he moved out of the dorms into an apartment. He was getting fewer colds, but he still had 5 sinus infections in a year and actually had a pneumonia. And so he was not that happy with his health, but he still continued to chalk it up to the college campus experience and just being around so many other young people. At 21 years of age, he was admitted to the ICU for pneumococcal sepsis. He did have a pre-existing URI and cough, but it was sepsis that landed him in the ICU. So does this history worry you? And I want you to think about, at what point would you have said to yourself, oh, that's a lot of infection? So I'll just go back and you can mull over that question. Would it have been when he first started getting infections, when he was in the dorms, or you would have been likely to say, oh, it's terrible in the dorms. It's terrible. That's what we all say, right? What about when he moved out of the dorms, but was still getting, 6 courses of antibiotics a year? And then I'm guessing by the time he was 21 and in the ICU, most of you would have probably done a workup. So I just realized I cannot see the chat, which is what I was going to use for this, but feel free to say what you think about when you would have personally felt this was an excessive pattern and started a workup. So some other information that might sort of color the story. He's an only child, both parents are healthy. As a young child, he had a few ear infections, but really hadn't had any antibiotics that his parents could remember until he entered college. He has no other medical conditions, does not have allergies. He works out regularly, he eats sensibly. There's really nothing else about him that is worrisome in any way. So how to approach this history of recurrent infections here? And we've been talking about this, but I sort of ask myself some questions so I don't get distracted. I don't want to jump too soon and go, oh my gosh, I'm an immunologist, I've got to order immunoglobulins. I like to be methodical. So could he have allergies? Not unheard of for someone his age to get allergies, especially if he moved to a new location. Maybe he's having mold exposure for the first time. So allergies, always worth thinking about. Could he have cystic fibrosis? Oh, this would be really old, but we're always asking ourselves if it could be. I guess it could be. I have to confess, I've never sent an 18-year-old, much less a 21-year-old for testing in the absence of a more extensive history into their childhood. Could there be an anatomical obstruction? Always worth asking this. Could he have a polyp? Maybe he's got concha bullosa. Maybe he didn't think to tell you, but he was wrestling and his nose was broken. Now his septum is deviated. So could there be an anatomical reason he's getting recurrent sinus infections? Not always so obvious on physical exam, and always worth thinking about, particularly if it's one infection site, the left sinus, for example. But he has two sites, right? He's got sinuses and lungs now. So once you start adding up sites, it's much less likely to be anatomical, more likely to be the immune system. So you always want to think about primary immune deficiencies. That's why we're here today. But don't forget the secondary ones. Those folks need help too. So HIV, malignancy, nutritional. Doesn't sound like it in this particular guy. He's working out, he's leading a life, his diet seems okay. But remember, across the world, malnutrition is the most common cause of immune deficiency, a secondary immune deficiency to be sure, but the most common around the world. And then there are a few drugs that can impact your immune system. There's the ones we think about, the immune suppressive medications like steroids, but there are some drugs, in particular, some older cardiac drugs and some older seizure drugs that will lower the IgG level. So in the history, I always want to think about the sites of infections. The more sites you have, the more it suggests to me that it's immune deficiency and not anatomical. Organism, not so much for this guy, but let's say it was a skin infection. I would want to be sure it wasn't a very peculiar organism, an opportunistic organism like aspergillus in the skin or nocardia in the skin, where I'd have to think about something completely different. And then the last bullet, I know you're all going to agree, this one's really tricky. Is this poor guy relapsing because someone's only giving him 5 days of antibiotics for every sinus infection? Is it really all one 4-year-long sinus infection and he's never had adequate treatment? Or is it a true recurrence? In his story, it didn't really seem like it, but certainly I've seen in particular kids that have come in, we're all trying to use less in the way of antibiotics. We're all trying to be good stewards, and they're getting smidgy little doses of plain old amoxicillin, and they've just developed this nasty resistant infection, and they're just not being adequately treated. So always worth stopping and asking yourself, is this relapse or incomplete treatment? Or are these truly unique infections and this patient has had a dozen of them now? Recurrent typical infections like this patient, otitis media, bronchitis, and pneumonia. This is the most common indication for a referral to my clinic, and it's the most common. Remember back in the flash talk, the European group, recurrent sinopulmonary infections, #1 reason for referral to an immunologist. So never want to forget this. I don't want to get too sidetracked down the other things. The diagnostic approach, a CBC and differential, actually gives you a lot of information. So neutropenia, we're all so trained to look for that. But don't ignore lymphopenia. More often in kids, but certainly worth paying attention to. 70% of your lymphocytes are T cells. If your T cells are low, there's a good chance that your absolute lymphocyte count will be low. So don't forget lymphopenia. We've already talked about immunoglobulin levels. And then vaccine responses we've also talked about, with tetanus being the strongest, diphtheria, if you like it, and pneumococcal being a good way of assessing, is this immune system cranking on all cylinders? Do I get a great pneumococcal response, or maybe it's got a little softness in it? So here's our patient. So I went through the sort of mental checklist. He didn't have allergies, his diet was good. So I get the labs. His IgG is 250 milligrams per deciliter. His IgA is undetectable. his IgM is 50 milligrams per deciliter. So if you're not used to looking at immunoglobulins, most adults should be over 500. So this is clearly low. About 1 in 500 Caucasians are IgA deficient. So having an undetectable IgA by itself, not that weird. And that IgM is normal. But he was vaccinated right before he went to college just a few years ago, and he has no vaccine responses. So that's clearly abnormal. So he fulfills the diagnosis of common variable immune deficiency. There's really three criteria for common variable: a low IgG plus a low something else, excuse me, and poor responses to vaccines, and poor responses isn't quantified. The third criteria is that there can't be another medical explanation like nephrotic syndrome or something like that. So this young man fulfills the diagnosis of common variable immune deficiency, and the standard treatment for that would be to give him infusions of antibody, sometimes known as IVIG. It can also be given subcutaneously. So he gets immunoglobulin replacement. Does this work? Well, his infection's abated, so he's a happy camper. He also comes back and says, you know, I didn't realize how beat up I was, but I have a lot more energy now. And he's now engaged to marry a woman that he met in college. So this is the perfect time to talk genetics, right? He's building a family like so many young people are. So in common variable, it is diagnosed by the blood work that I described, the immunoglobulins, the titers, make sure there's no other explanation. But among the entire cohort with common variable, about 30% have a recognizable monogenic cause. That's really useful for people that are planning a family. So it's worth doing genetics for people that are thinking about getting married and having kids. So I would do it in him. If he was 60 and came to me with infections and nothing else, I might or might not do genetics, because the genetics isn't going to help him in the moment, and I don't need it to treat his infections. So more and more people are doing genetics for all patients with common variable, but it's not standard of care across the entire United States yet. So I'm going to end in case there are some questions cropping up. Oops. Okay, I think we're back now.
So we have, I've been updating the chat a little bit. I can read out some of the questions if that's helpful, Kate. So one is from Colleen. Should all sinus infections be cultured so you know if there are different causes for the infections? And does that make a difference as to whether or not this is a primary immunodeficiency?
That's a really practical question. So I'll usually treat a few times before I culture, because the cultures are actually pretty hard to get. So you have to actually go in and do a sinus aspirate. Not easy to do, requires an ENT person. And it has to be an ENT person that's willing to send the culture for bacteria, for anaerobic bacteria, for fungi. And so not every ENT is equally empowered to do that if they're not hooked up to a good lab. So I'll usually treat a few times. And then if I feel like, oh, this really does feel like I'm not eradicating the infection, then I'll ask an ENT person to do a culture. Paula, I don't know if you have a similar practice or not.
Yeah, I'm not in the practice typically of getting sinus cultures or cultures unless there is a significant concern, in which case I'm working co-managing with ENT, or I'm referring to ENT for further culture. So usually not, but I mean, it's a great thought. Another question and comment, thoughts about with relation, I think, to your case, concern for ciliary defects in the settings of recurrent otitis media, sinus and lung infections. Should we be should we be evaluating for ciliary defects when we have recurrent otitis media, sinus infections, lung infections?
Yeah, Dosan, great thought. I'm actually kind of embarrassed. Like if I put cystic fibrosis on the slide, couldn't I have added ciliary dyskinesia? So I'm a little embarrassed that I didn't. I tend to think of them together. So this patient was a little old for that, but with such a high frequency rate, I know our pulmonologist, if he had one more pneumonia, our pulmonologist would get the genetic testing, which is the standard now over and above the ciliary brushing that we used to do. So I think you were right to bring that up. It was neglected by me, sorry. Other comments?
I'm going to bring up the elephant in the room as far as COVID. If you have a patient who has recurrent cases of COVID and has a slight history of infections that are off and on, at what point is it warranted to look at? They're vaccinated, they've been sick. Is that sort of a red flag as to, you know, now you're on case 2, you're on case 3, you've had a few other infections, maybe one pneumonia in life. At what point when we get related to COVID do you look at PI?
So there's a big-ish body of literature now on severe COVID, which is not your question, but since you brought up COVID, I'll just mention it in passing in case people are not aware of this literature. Among folks who don't have an obvious risk factor, so they're not 80 years old, they're not, you know, they don't have a medical risk factor, who end up in the ICU with severe COVID, about 5 to 10% have, 5 to 15%, depending on the age group, have either a genetic flaw in their immune responses to viruses, or they have an antibody that compromises interferon signaling. So 5 to 15%, it's not a big slice of the pie, but those folks are at risk for future severe COVID. Your question was actually subtly different. What about COVID recurrences? So COVID, sadly, so sadly, is not like a lot of other organisms in that we don't produce long-lived antibodies to it. So if you look at people that have natural infection, depending on the severity of their infection, they can have antibodies that last 6 to 9 months, or they can have antibodies that last as little as 3 months. And it tends to track with severity, although that's not the only variable. If you get a vaccine, the median time for protective antibodies to last is only about 6 months. So it's not like chickenpox, where if you get recurrent chickenpox, it suggests that you're not making great antibodies to the vaccine or the virus. SARS-CoV-2 is it's just such an unpleasant pathogen. So it doesn't induce a long-lived immune response, and that means most people can get COVID more than once. Sad.
One question that we had at the very end of last session that we really weren't able to tackle effectively was how much testing can and should the PCP do before sending them over to the immunologist? And like, you know, in terms of, should they be getting immunoglobulins, the titers, and what would be your recommendation moving forward? Or do you recommend just sending to the immunologist? And yeah, I think that the group would love your input.
I don't really have a rule. I think the PCP should do as much as they feel comfortable doing. If they're comfortable getting immunoglobulins and titers, I say rock on. And if they're not, I am very happy to see their patients and send them back with hopefully what is a helpful letter. So I think, and I hold myself to the same standard. I am terrible at endocrinology, just terrible. If it's not a thyroid problem, I can't tackle it. So if someone seems like they might be hypothyroid, I will test them for it. If it's anything else, I send them to endocrinology. So maybe because I recognize my own limitations, I never want to make someone go out of their own personal comfort zone.
Kate, excuse me. I know we only have a few minutes left, and I want to make sure that, are you able to see the chat? Because there were some questions that were coming in.
We've addressed all of them. I've gone through all of them.
Okay, Colleen is saying
Have
no.
we not?
So if we missed any, somebody please read them. I've been
Okay,
trying
if you could
to
read the very
translate.
last one.
Have I read?
Have I had
Which
PI
did I meet?
patients?
Which one did I miss? Could you read the one I missed?
Have you had PI patients have sinus culture with Enterococcus S faecalis growing out?
Oh, I didn't see that one.
I didn't see it either.
That's not,
I don't know what Enterococcus S is. I'm so sorry, but I have had, I've actually had Enterococcus from the lung and from the sinus, which I think is ick.
Sounds ick. Yes, that I will share with all of you and congratulate you, Kate, and everybody, that I do believe in the process today we have diagnosed a patient. So the doctor who has asked the question is going to send in a consulting immunology request and get further help, but looked back on labs that you suggested and found there is indeed things that are an alarm. So
How lovely is that?
wonderful.
I just wanted to add on, like, the personal note of getting my son diagnosed, and how important that the primary providers listen to and have that aspect of thinking that there's something wrong. In a short personal story, my son, I thought something was wrong with his immune system, just because when we all got the same sickness, he always ended up so much sicker than the rest of us. But the short personal story is that he's in a big pediatrician provider group. There's 6 of them. And I went to the one and I said, doctor, this is I think it was like the 12th time he had strep throat. And I said, is there something wrong with his immune system? And he said, no, he would present differently. 2 weeks went by, he was sick with something else, sinus infection, ear infection, whatever it was. And that doctor, I said, doctor, is there something wrong with his immune system? And he said, no, he would be in the ICU. That's not how this is diagnosed. And sure enough, a couple of weeks later, and by this point, I think I'm crazy, I meet with a third doctor of the practice for another sick kid visit. And I said, doctor, I feel there's something wrong with his immune system. And she goes, well, I have made a vow never to go against a mother's gut. And she goes, well, I don't think this is probably the course. And I said, I'll do anything, any blood test, any whatever you can think of. I just feel it. And she goes, Diana, I'll write the orders. So she did a primary, like the quantitative IgG, IgA, IgM. She knew which titers to draw. She drew them and she called me 3 days later. And she goes, Diana, there is something wrong. We need to get you to an immunologist. We'll get you there. But I stuck with the practice. And part of why I stuck with the practice is those 2 previous doctors learned that they literally told me that's not how it presents, just relax. And I was like, but there, and I just said, okay. And I wasn't as strong of an advocate as I am now, but they both personally called me and told me, I am so sorry. And, we now have one primary doctor that I talk to because he specializes more in, conditions such as this for a primary. And they didn't want to miss going to several doctors when something is awry. But as that part of the personal note, that's what I want to express to the primary providers out there. It may not be typical. We're not in the ICU yet, but also when a mother's gut is saying something isn't right here, I didn't want anything to be wrong, but something was definitely missed for quite a while. But
I would add too, I was 17 and healthy, running track when I started getting sick and had literally a whole spring of just getting sick from sinus infection after sinus infection. It also went to the tonsils, and I ended up having to get my tonsils out at 17. after they struggled to try and get the infection to go away enough to take them out. And so I'd add tonsils into your idea of lungs and sinuses.
Thank you, everyone. I hate to stop this, but we stop at 1. I want to respect all of your time. Please, any last questions for Kate, for any of our hub specialists here, please put them in the chat. We'll make sure that we get to them. Thank you to the few people who reached out about having cases for the future. We'd love to talk about your cases. Real quick reminders, you will be getting an email with a link to the evaluation. If you're claiming CME, you do need to complete that. We are back here again April 24th, and we'll be talking about antibody deficiencies. And I'm just going to ask Kate, if you have any final comments before we log off, feel free, but thank you so much for sharing your expertise.
I think Ken and Diana raised points in their own way that immune deficiencies are invisible. People look great on the outside, and that's why it's so important for us as clinicians to be thinking of it, because the patients won't necessarily show us on their physical exam or their x-rays.
Okay. Thank you so much. See everyone on April 24th. Have a great rest of your day.